Mhm. Hello, everyone. Thank you so much for joining us today. I hope you're having a good Wednesday. It's been a few weeks since we last had a webinar, so I'm excited to be back with you all. We're going to give it just a moment before we go ahead and kick off. All right. Okay. All righty. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today is on musculoskeletal ultrasound. The future is now. My name is Alison Murtha, and I'm the manager of strategic communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff monitoring these questions, which we will pose to our speaker after the presentation. And if you're watching on one of our streaming platforms, go ahead and drop your questions in the chat feature. We'll make sure to pull those as well. This webinar is being recorded and will be available to the community beginning on Friday, September 16th. I'm joined today by Peter Aguero. Thank you for taking the time to join us today. I'll go ahead and turn it over to you to get us started.
Thank you, Allison. I just want to check, are you able to see my cursor there?
I can, yes, yeah.
Okay, perfect, that's gonna be important. All right, great. Well, my name is Peter Aguero. I'm a physical therapist over at the University of California, San Diego, at the Hemophilia Thrombosis Treatment Center there. And today we're gonna be talking about musculoskeletal ultrasound, or the abbreviated version we use Mskus. The future is now. So we're gonna be going over why I use musculoskeletal ultrasound in my practice with patients with hemophilia, why I think it's important, and kind of the uses that it's being used for. Let's go ahead and get started. So I promise this is the one slide that we have that's going to cover physics of ultrasound. I was never really strong at physics, so I kept it just to one, very simple, but it's important that we know about kind of how the ultrasound works. So we have on the bottom right-hand corner, we have that picture of the ultrasound machines with the screen. And so what the ultrasound does is through that machine, it produces acoustic waves, so these sound waves, and they exit out of the little probe that's connected to the machine. And these sound waves enter into the body and interact with the tissues underneath the skin. So based off of how they interact, those sound waves interact with the tissues is how they're going to present on the screen and as a 2D image. So for example, let's say a sound wave enters into the body and hits a very dense, a very stiff tissue like bone. What it's going to do, it's going to reflect all of those sound waves back up to the machine. And those reflections back up to the screen, those are called echoes. And depending on the stiffness and the density of that tissue, it's going to give you a different appearance. So those structures and those tissues that reflect all of the echoes back up to the machine, those tissues are going to be really bright and white. Whereas other tissues, which are going to absorb a lot of those echoes or sound waves and are not going to reflect any sound waves back up to the probe, those are going to be very dark. So things like simple fluid, things like cartilage, things that have a lot of water content inside of them are going to absorb a lot of those echoes, and so are going to appear very dark. And then you have tissues in between, like tendons and muscles, that are going to kind of be maybe not as bright, but not as dark as fluid. And so those tissues are going to have a more of a gray appearance. So based off of the brightness of that tissue is going to give us an indication of what kind of tissue it is. So a little bit of history about ultrasound is that it's been used a lot since the 1940s. It was mostly used by two groups of physicians, mostly rheumatologists and OBGYNs. With rheumatologists, they use it to look at their patients with rheumatoid arthritis and look at their joints and cartilage and bone. And then, as we know, most of us know ultrasound with the OBGYN doctors and looking at babies inside of tummies. So since then, there's been a lot more providers that have been using musculoskeletal ultrasound. specifically rheumatologists, more rheumatologists, even orthopedic surgeons and interventional radiologists use it for ultrasound guided procedures. And then we also use ultrasound, not in a musculoskeletal fashion, but in, different body systems with echocardiograms and looking at, vessels and looking if there's any thrombus, deep vein thrombosis or DVTs. A lot of doctors look at that, use ultrasound for that. And now we have hemophilia providers, both hematologists, nurse practitioners, and physical therapists that use it in order to look at joint bleeds. And we'll get into that more later, the upcoming slides. And a little stat at the bottom is since 1996, from 1996 to 2006, ultrasound in the musculoskeletal system increased to 200%. And obviously that number is probably a lot more now. So these are just some examples of the different ultrasound units that are available right now. We have these big console units like the one I have at my clinic. Those are very, very expensive. And then we have everything in between. We have a laptop version, which is a little bit more mobile. You can pack it into a suitcase, take it from place to place. And then we have these smaller handheld units that are getting a lot better as time progresses, as more and more people are using it. The first generation of handheld units were very rudimentary. They didn't have very good quality. They didn't have a lot of good features on it. But now, as technology has improved rapidly, these handheld units are becoming a lot more, the quality is a lot better. And so, so it's making great progress with that. So why we use musculoskeletal ultrasound as opposed to like an MRI? One is that there's no radiation. The acoustic waves they're different than microwaves. And so the microwaves that is producing radiation from an MRI machine and from like an X-ray are there are some level of radiation to it, and that's why they put when you go to the dentist and you have that big lead collar on, that's to protect your body against that radiation. Whereas with an ultrasound, it's acoustic waves, so you don't have any radiation associated with that. There's no sedation, especially for small children. Think about those patients who are really small and anxious or have trouble going into like these very tiny, really, really loud MRI machines. It can be really scary. And so with the ultrasound, you don't need to do that. It's very quiet. You don't need any level of sedation with that. No, there's no thermal effect. Now there is a type of setting that you can put on, not this specific ultrasound, but other kinds of ultrasound machines where you can increase the frequency and actually cause a little bit of a heating effect. But we're dealing with a little bit lower frequency with this, what we call diagnostic imaging, where we're able to see things. And with that, there's no, it's not going to cause any heating inside of those tissues. It's readily available in the clinic. You don't have to send someone off to the radiology department to go get a picture done. And also, one of my favorite parts of ultrasound is the dynamic imaging aspect, which is a huge advantage when it comes to, in comparison to X-ray and MRI and CT scan, is that you're able to move the joint. Life is not a still picture. Life is movement. Our bodies are constantly moving. And so being able to capture that with an ultrasound and able to record these different movements and seeing the tissues move as you're moving the patient, or as the patient is moving, is a great feature and advantage of ultrasound. So why is ultrasound preferred over MRI in certain aspects? So one of the aspects that ultrasound actually has a better advantage over MRI is that it has better resolution. Now, you might think, oh wow, like that's really surprising. Like MRI is, really cool images, and you can see slice by slice the whole body part. But when in actuality, when you think about when you're dealing with the resolution, the quote unquote resolution of an image, you're dealing with similar to a resolution on a TV. So in the TV you have and like laptops, like what you're seeing now, is pixels. So in With a TV or laptop, the higher the pixelation rate is, you're going to have a better resolution. Those boxes are really, really small. Whereas with in imaging, like with MRI and ultrasound, you have what are known as voxels. So they're pretty, equitable to pixels. And the voxels in an MRI are actually 4 to 20 times larger than the ones in musculoskeletal ultrasound. The musculoskeletal ultrasound has a better voxel rate or pixel rate. And so you're going to have better resolution when it comes to ultrasound. In addition to that, not only are you dealing with smaller voxels with ultrasound, but you're able to account for these curved surfaces. So think about with an MRI, it takes a picture of a slice and then it moves down another picture, moves down another picture. But you're dealing with, let's look at the picture on the left where it's a curved surface. Let's imagine that curved surface is the end of the femur or end of the thigh bone. Each one of those lines, of those red lines, is a picture that the MRI would take. But you can see the space in between each one of those red lines is a missing part or missing space that is not being taken a picture of. So you're missing a large portion of that structure. Whereas with an ultrasound machine, you're able to kind of go around and use the probe to go around that area and see the entirety of that curved surface. So in that way, with curved surfaces specifically, is that so ultrasound is a little bit better when it comes to that. One thing that I will say that MRI does really good at, two things. One is differentiating between tissues, looking at different tissues and figuring out if there's something going on and figuring out what kind of tissue it is. And then also that an MRI is able to look inside of the joint, intra-articular. So with an ultrasound, we're only able to see so far into the joint, and ultrasound is not the gold standard when it comes to looking at the differentiating between tissues. However, when you're looking at differentiating between fluids, Mskus or musculoskeletal ultrasound does a significantly better job at that, at differentiating between different types of fluids. So, for example, what's relevant in the hemophilia world is differentiating between blood and simple fluid. So in a study back in 2017, ultrasound is able to detect down to 5% blood within fluid. It has a different appearance than if it was 0% blood and just simple fluid. Whereas with an MRI, it's able to do that to a certain extent, but not down to as low as 5%. So as you can see, the top two images of the MRI, we can see that there's fluid, but we can't differentiate which one's which, whereas down below, the ultrasound is the image on the bottom left, that is a knee joint, and we're looking at that big black space right here. That's very, very dark. That means that's all simple fluid, whereas here we see this area is also dark, but it has all these little speckles in it. And what that means is that this is a joint bleed in that, and the reason why we know it's a joint bleed is because of that speckled appearance. When blood is in fluid, blood cells are in fluid, the ultrasound, going back to the physics, that those sound waves hit that fluid, but then within each individual red blood cell, there's an iron, there's a little iron deposit. And so iron in itself is very stiff and dense. And so when the sound wave hits that iron, it reflects back up to the probe and gives that kind of speckled appearance. And so that's how we know. That's how we know that it's able to differentiate between blood and fluid, which is very, 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 very important when it comes to hemophilia care and detecting joint bleeds. So how do we use ultrasound in the bleeding disorders clinic? So this is one of my most important slides here, is that it's not something that we use just as a standalone evaluation. We always use it as an extension of our evaluation. When I look at patients, I still do my subjective assessment. I still do my objective assessment. Think of it as something like a very specific and sensitive special test that we use. It doesn't replace our objective assessment. We use it to help confirm or to help deny our hypothesis of what might be going on. So we'll go more into these aspects, but the uses of ultrasound within an HTC, a few points. So we have point of care. It's answering a yes or no question, and we'll go more into that. We also use ultrasound for longitudinal comparison of joint progression, whether it be during annual visits or if a person has a joint bleed, and then we want to track how that joint is recovering after that bleed. Another aspect is using it investigatively, looking at if a patient has a specific amount of pain, a specific pain in a specific area. We want to see, what is causing that pain. And so that's one of my favorite parts is using the ultrasound along with my objective and subjective assessment to figure out what's going on with that patient. And then also we use it for research and using it to objectify our findings, giving a patient a specific intervention and tracking and seeing, if that intervention is helping or not doing any change to their joints or tissues or whatever we're investigating. So point of care, we like to use the acronym POCUS, which is basically answering a yes or no question for us. So the most common one that we use in hemophilia care with ultrasound is there a bleed or not? Is there blood inside of this joint or not? Other questions might be, is this area healing or not? Is the cartilage degrading faster than normal aging process? Is the bone degrading or not faster than the normal aging process? These are all questions that ultrasound can help us answer. So again, these the point of care questions, the yes no questions, give us an answer, and then these answers can help drive treatment in informing us and giving us a specific answer and helping us determine what's the most appropriate treatment for that patient. Because if a person has a simple effusion versus just some normal joint swelling without blood, it's going to be treated differently than someone who has a joint bleed. So it helps us answer that question. Some tools that I use and people use with ultrasound is the use to answer these questions would be power Doppler. So you can see on the top right image video, is this little feature of the ultrasound. This is a little yellow box that you can put over a specific area, and it'll help tell us if there's angiogenesis happening, which is a really fancy way of saying if there's any inflammation happening. And so it can help us answer that question, is there inflammation happening or not? Another question or another feature that we could use is the use of dynamic imaging, which I love to use. So dynamic imaging, I kind of mentioned it earlier, which would be to have the patient move, or you move the patient while you are ultrasounding them and viewing the image. Another form of dynamic imaging would be what's called sonopalpation, which is you using the probe to kind of put some compression through the skin and then releasing it. And what that does is it allows you to kind of see the characteristics of those tissues. And so, for example, if I were to take a still shot of the image on the bottom or the video on the bottom, I could gather some information from that, but what's going to give me more information is the characteristics of that tissue. So looking at that big blob here, we know that when I press into it, it kind of goes away. It disperses, and I want to let go, it kind of fills back up, letting me know that characteristic of that structure is fluid. It acts as a fluid. And so then I'm able to answer more questions and it helps give me more information about it. As you can see, there's some little floaty things in there. I don't know exactly. I think they're probably pieces of tissue, pieces of synovium that are kind of floating around in that pocket of fluid there. So longitudinal comparison. It's just that. It's just looking at a set of baseline images and then comparing over time those images from the previous one and seeing if there's, for example, less blood than before, or if there's less synovial thickening, or if there's more degraded cartilage, or how is this tissue healing? So using ultrasound to kind of track how the tissues are looking and how the tissues are reacting and healing. And so what I like to do is I like to have a set of baseline images for all of my patients. And then hopefully, usually every year, I take those same images and track it over time and looking at their cartilage and seeing if their cartilage or bone is degrading faster than say like the normal aging process. Because if it is, then that's something that we need to talk about and we need to address. Another trick that you can do is looking at the uninvolved side. So let's say if someone has a target joint of the right knee, we can look at the left knee if they haven't had any bleeds there and kind of see what it's supposed to look like, and then and see what the target joint knee looks like, and compare the two and see what needs to be addressed. This is my favorite part, is the investigative. So typically when a patient comes into the clinic with pain, someone is going to evaluate them, whether it be me, the physical therapist, it might be the hematologist, it might be the nurse practitioner. But usually it's me, because I'm one of the people who's the most trained with using musculoskeletal ultrasound and how it's an important part of our evaluation. And so I'll still do my subjective assessment, I'll still do my objective assessment, and then I'll do usually a set of standardized images. So these protocols, a couple of them that I listed here, but the JADE and the HEAD US. The JADE was actually developed here at UCSD, and the HEAD US was developed over in Italy. Both are great protocols, and they give you set images that are in specific areas that are usually the most affected areas for patients with bleeding disorders. Now, sometimes those areas or the painful area that the patient is complaining about is going to be not near where that standard image is. And so that's where the investigative aspect comes into play, in moving the probe outside of those standard images to figure out what's going on, using dynamic imaging to move. The patient might say, "Oh, it hurts my leg when I move it this way." Like, okay, well, let's put the probe on it and have you move that way and see if I can see anything. So that's a really great way of using ultrasound in this kind of investigative fashion. So, and then lastly, with research, there's a few different ways that we've been using it for research. One way is looking at standardization of like what joints are supposed to look like and what tissues are supposed to look like at different ages. Another aspect is, which is pretty big right now, which is using prophylaxis, or using ultrasound as a way to objectify the effect of prophylaxis or different types of medications on their joints, and how if it's improving or it's not doing anything to their joints as far as their bone and cartilage and things of that nature. And then most recently, we're developing the use of handheld ultrasound and putting it in the hands of patients. So I just completed a study. It was published actually about a couple weeks ago, about using handheld ultrasounds with patients and guiding them in how to ultrasound themselves. So in the case of like a situation where a patient thinks they have a bleed at home and they can't get to the clinic because they live really remotely or they live really far and they can't get to the clinic to get ultrasound, they can do it at home and with my help. And so that's looking at the feasibility of that. So I'm happy to share that with you all. Okay, so what are we looking at specifically with ultrasound is we're looking at the different tissues, specifically the really bright ones, the really dark ones, and the ones that are kind of gray in between, and seeing if they are normal in the sense of a bone is typically supposed to be very, very bright, and seeing if it's bright, consistently bright throughout. If it's not, then there might be something going on. So looking at tissues that are very dense and stiff like bone are going to be very bright. Things that are very dark are going to be very have a lot of water content in them. And then everything in between is going to be a little bit more gray. So let's look at what tissues, types of tissues what kind of normal brightness do they have to them? So normally muscle is supposed to be very dark. 70%, I should say muscle is 70% water, which is a big reason why we need to stay hydrated throughout the day. And those little white lines that are kind of in between the dark areas of the muscle, those are called the muscle septum, or they're kind of, think of it as like a sausage casing. They're kind of just the casings around each muscle bundle. And those are typically going to be very, very bright because they're a little bit more, have a little bit higher, not as much water in them, and they're a little bit more stiff. Cartilage is also mostly water. It's 80% water. So another reason why to stay hydrated. Actually, we'll take a sip of water. So cartilage is 80% water, which is the reason why it's so dark. And therefore, healthy cartilage is going to be almost completely black if it's really healthy and hydrated. We also have to think about what the differences be in ages. So an adult bone is going to look a lot different. Bone and cartilage is going to look a lot different than a child's bone and cartilage. You can see if the two images here, I was to assume that they were both, adults. I'd say, oh wow, the person on the right, they have a fracture on their leg bone, on their thigh bone, when in actuality it's just the growth plate of that child, and that's a very normal appearance for that age for this child. So we have to use that into consideration when looking at ultrasounding adults versus children. So if you're looking at a joint, where does the joint fluid come from, and where does it start? And so in this specific joint, this is the elbow. This is specifically the humeroradial joint, and it's kind of the joint. It's on the outer aspect of our elbow. It's the joint that's responsible. Its big responsibility is to rotate our hand up and down like this, and so. The joint, you can see on the left-hand side, and I'll point it out here, we have the end of the humerus, or end of the arm bone, and then we have the top, or the beginning of our radius, or forearm bone. So in between the two, we have the joint space. So the fluid, it's going to originate within the joint and kind of exit out and start to make its way. If there's an excess amount of fluid, it's going to start to make its way outside of the joint and kind of sit right in between these two arrows. You can see, we'll go over more, that this bright triangle-y kind of structure here, that's the joint capsule. And it's actually, if there was fluid inside, it's going to push this superficially up towards the top of the screen. And where this kind of white area is collecting right here, that's going to be pushed up, and it's going to be filled by a dark structure, which would be fluid, if there's a joint effusion or bloody effusion. So why is bone brighter under the hyaline cartilage and joint fluid? So this is an interesting aspect of ultrasound, in that because cartilage is mostly water, and water is 100% water, it's going to be really dark, and it's going to absorb all of the sound waves that enter into it. But when I say absorb, I don't mean that it's going to take in and hold on to those sound waves. What it's actually going to do is going to propel them through. It's going to act as a medium. So think of it as so when the ultrasound probe shoots sound waves into your body, it goes in at a certain speed. And so when it hits these structures that have a high water content, or it hits water or fluid, it's actually when it goes through that structure, it's going to increase its speed. And so when it hits that bone that's underneath it, it's going to hit it at a really, really high speed. And when it hits that bone at a really high speed, higher than it normally would, it's going to reflect it, go back up to the probe at a really high speed as well. And so that's why it's going to be even brighter than the same structure, the same bone, maybe in a different area that's not underneath cartilage or underneath fluid. And so it's an interesting, what we call artifact or effect that the physics of the ultrasound can have on tissue. And it tells me, if there's a piece of, a little bit of fluid that's going on, and I see that it's causing a lot of this brightness underneath it, then I know that's one indication to me that this structure that's sitting there, it has a lot of fluid in it. So how do we determine cartilage from fluid? Both are black, both are very dark. So how do we figure it out? So whoever's doing the ultrasound has to know their anatomy very, very well, because cartilage is only going to be in very specific areas. It's going to be in areas where bones are articulating with each other to create a joint. And whereas fluid, it could be pretty much anywhere. So if someone who's performing the ultrasound, they don't know their anatomy, it can be really hard to tell whether a certain structure, a dark blob, is fluid or whether it's cartilage. And so you have to know your anatomy, but then also dynamic imaging helps as well. With compression, you can sonopalpate, you can press the probe into the tissues, and if that tissue doesn't move, it could be cartilage. Whereas if it kind of goes away, disperses, and then comes back, it's fluid. So going back to this kind of structure here, what we call the joint capsule. The joint capsule is a very strong fibrous tissue that kind of surrounds the joint, kind of holds it together. And so what we want to see in most joints is this kind of what we call tornado sign, or this Ving into the joint space. That's a normal, that tells me that there's a normal amount of fluid within that joint. If there is a swollen joint that has excess fluid inside of the joint, it's going to push that V up towards the top of the screen. And where that V is right now in this picture, it's going to be filled with fluid. So that capsule is going to be kind of distended up. And so when I look at joints, I look for that V and see, hey, is there a normal amount of fluid in that joint? Because every joint is supposed to have a little bit of fluid in it. And then another aspect that I want to touch on here is that the joint capsule is also very, very stiff and dense, and that's why it's such a bright structure. It's almost as bright as the bone itself. And so that's another aspect that I look at. If it's a little bit darker, or if there's an interruption within the joint capsule, then that tells me, okay, there might be something going on there. So again, the joint capsule is very, very thick, very dense, and even actually some of the fiber in some areas, some of the fibers of that joint capsule blend in with the surrounding ligaments around that joint, which makes it even tougher and even stronger, giving it a really bright appearance. So now we know kind of the different structures of a joint capsule, cartilage, fluid, bone, what they look like normally. So now we want to look at what pathology those tissues under pathology look like, or things that are not normal, or going through injury or going through healing. So this is a picture of the end of the femur, or the end of the thigh bone. And this is the image on the left is a fairly healthy end of the thigh bone. It's called the sunrise view. That is one of those standardized images, and we see this normal kind of curvature within the bone. That's a normal curve, very even throughout, which is nice. We want to see the bone nice and crisp and consistent throughout. You see kind of right here a little bit of jaggedness, which means that it's A little bit degraded, but it's not horrible. The cartilage itself, now we look more superficially, we look at the cartilage that's sitting on top. I know that it's cartilage because I know my anatomy very well, and this is a pretty standardized image. But we see that it's a little bit gray in some parts. It's not completely black like in the previous elbow image. So there is it has a little bit of loss of water content inside. So it's not as healthy, but it's still, it's consistent throughout the thickness throughout. So it's not completely degenerated. It's a fairly healthy knee joint. Whereas we look at the image on the right is not consistent. It starts pretty flat, then it kind of dips really far down. You see that big divot in the middle. You see the bone is very, very irregular. It's very jagged. It's not crisp and straight and clean like on the left-hand image. And we hardly see any cartilage. We see a little bit here on the top left, but that's pretty much it. There's a lot of degeneration that's happening in this end of the femur. And this end of the femur is because there's cartilage on it, that means that it's part of the knee joint itself. It's going to articulate with the end of your leg or the top of your leg bone or the tibia. And so I can already tell that this patient is probably going to have some pops and clips and crunchiness that's associated, because it's not going to be smooth surfaces like it would be on the image on the left. It's going to be very jagged. So you're going to have some, popping and clicking and jaggedness and crunchiness. There might be some loss of range of motion. There might be some pain too. So this is a kind of little bit of a case study here. On the left, we see a fairly normal shoulder joint. So this image is going to look at the front part of it's a kind of a cross section of the front part of your shoulder. This bright white bone here, that's the humerus or the top of your arm bone. And then we see that it kind of starts rounding over the top, and it kind of takes a big dip down, has a big, huge valley right here, and comes back up like this. So this is the intertrabecular groove of the humerus or of the arm bone, and sitting within the groove or this valley is the biceps tendon. So you have your bicep muscle here, you have your tendon that comes up. Actually, it comes up into your shoulder joint itself. And so this is so high up on the shoulder that we actually see the joint capsule of the shoulder joint that's kind of running over the top here. Going more superficially, we have the big, nice and dark deltoid muscle. It's very dark, which is good. And then we see the skin at the very top. Now we look at the image on the right. We see a fairly healthy bone, kind of dips down a little bit. The tendon here is a little bit darker than on the left, but then we see this big, huge mass that's sitting in here. That's not supposed to be there. Then we see up top, we see the joint capsule up here. We can see how close on the left, how close to the bone it is, as opposed to the image on the right, where you have this big structure that's right here, that's distending, ballooning the capsule up. We even see a little bit that deltoid muscle is a little bit brighter. It's not as dark as the one on the left. So that tells me that there's something going on there. And then this is actually a video. Let me go ahead and play it. And we can see it with some sonopalpation of pushing in. It's kind of squishing. Some parts are kind of smushing and then releasing, and then other parts are kind of going away, dispersing, and then coming back. So it's a very, very kind of complex structure where some of it acts more like fluid, other aspects, act more like tissue. So looking specifically at this, the image on the right, we notice how the joint capsule is also, it's pushed up. It's all the way up here. Then we notice the gray speckles. So in this area specifically, we know that this is acting very fluidy, and we see a lot of these speckles that are kind of going on in there. So that tells me that this is not simple fluid. This is blood. This is blood that's sitting inside of the joint. And I know it's inside of the joint because it is underneath that joint capsule. Now we look at this shoulder joint a little bit later, 2 weeks later. and we see that the structure is still here. Now the joint capsule over the top is still underneath that, but what we're seeing now is that it's less kind of bulbous and big, and it's kind of flattened out a little bit. We see the edges of it are a little bit brighter than this area in the middle. We see these kind of lines that are kind of coming in through the middle of it. And those are what we call fibrin strands. And that's an indication that this area is healing up. Your body is sending in white blood cells and other types of cells to try to heal the area, break down the blood and coagulated blood that's in there and start to heal it and start to repair the joint capsule in that area. So this is an example of kind of using ultrasound longitudinally over time to kind of see, how this person is responding to different interventions, whether it be war factor or whether it be, immobilization or physical therapy or things of that nature, and seeing how it's responding. Looks like it's whatever intervention that they are giving this person is working because they are healing. So in summary, the positives: there's no radiation like MRI. You don't need to sedate people with it. You can have people in a very comfortable position and still be able to see what you need to see with the ultrasound. It's inexpensive when compared to MRI. Obviously these ultrasound units are very expensive. They can be anywhere from $2,000 to $60,000 plus dollars. But when we look at that, a single scan versus an MRI single scan, it's going to be way more inexpensive. It can be done immediately. You don't have to wait to send someone to the radiology department. Gives you real time information and giving us answering a yes/no question, which can then help drive treatment. It helps us compare longitudinally. It gives us really good resolution compared to MRI, and it's portable. It can be portable with a laptop or handheld version. Some drawbacks: it's very, very, very operator dependent. The person who's ever operating the ultrasound unit has to be very competent with what they're looking at. With ultrasound, with a single movement like this much movement, you can make the image look completely different and even make it look pathologic. So that's why those standard images are so important to learn, because you know what it's supposed to look like. But in addition to that, the person who's performing the ultrasound has to know what they're doing and has to be comfortable with the machine and also have a really strong grasp of their anatomy. And then another drawback, like I said with back in the earlier slides, compared to MRI, is that you can't see through bone. You can't see really deep into the joint. That is when an MRI can be very, very helpful when you suspect that there's something intra-articular that's happening. In addition to that, ultrasound cannot differentiate between tissues very well. MRI is still kind of the gold standard for that. So I hope this presentation got you really hyped for ultrasound, and I love ultrasound. It's a very big passion of mine, and so I hope that you learned a little bit today, and I'm happy to answer any questions. And thank you for coming.
That was great. Thank you. Before we get started on the Q&A, if anybody has anything else that they want asked, please go ahead and throw it in the chat. We do have a poll for you today as well. So if you can answer this before we get started, that would be lovely. I do have a couple questions for you today. So I'm going to go ahead and get started on those. Let's see. So how often can a given individual receive an ultrasound? Is there a limit on how often they can receive them?
That's a great question. So it's really going to depend on the clinic. So the short answer is no, there's no limit. I've had patients come in every day for like a week or more to get repeat ultrasounds to see how they're progressing. But what can be limiting is the person that's performing the ultrasound may not be available every day. And so you're more limited by the availability of the operator than the ultrasound itself. It's not unsafe or anything like that to have multiple ultrasounds in a day or even over the course of a week, unlike an MRI where you don't want to have MRIs every day because that's a lot of radiation. But with ultrasound, it's completely safe.
Great, thank you. How do you suggest someone goes about getting their own handheld ultrasound to maybe use at home?
Yeah, so if we're talking specifically about the study, and I'll touch on other aspects, but with the study, our hope is to be able to, our results showed that with ultrasound, the patient, that if a provider, or so if a patient were to get an ultrasound machine or handheld unit, they actually do very well initially when they first learn how to use it, but then over time, they're not very good at it. Unlike me, who I use it every day in my practice, and I went to school and had a lot of training on it. And so I'm able to kind of guide the patient through that. And so as a patient, I wouldn't recommend buying one. It's a lot of money for something that you may not know how to use. But the hope is that this study is kind of the first of many to try to justify having patients, having a handheld unit for patients, maybe those that are in kind of remote areas, to be able to do an ultrasound on themselves with the assistance of a provider. Now, if you're a provider and you want to be able to have one and practice with it, and then maybe take a course for it to learn how to use it, yeah, there's no ultrasound police. You're totally able to go purchase one and then start using it right away. Obviously, like I said before, the ultrasound is very operator dependent. So you have to know how to use it, or else you're going to, you might make a misdiagnosis. And so I would highly recommend doing a lot of training and reading a lot of books to be able to learn how to use it. Now, as far as courses, there's a course here at UCSD. If you Google UCSD musculoskeletal ultrasound, our course will pop up, and it's free for hemophilia providers. And you'll be able to learn the JADE protocol and the standard images, and be able to use that handheld ultrasound if you purchase one.
Great, thank you. You touched on this just briefly, but I'm going to ask anyways. Is there anything that we should be aware of when it comes to completing an ultrasound on ourselves at home?
Yeah, so as a person, if you are not trained to use it, I wouldn't take anything. It'd be very, very difficult to determine what you're looking at. And so I would have, if you're going to do an ultrasound on yourself, again, there's no ultrasound police. But as far as, so you could purchase one if you're a patient, which is, it's something that you can do, but and you can learn how to use it, but I wouldn't make any diagnosis on yourself based off of that without the help of medical professional. It's like with anything. You have to reach out to your team at your HTCs to help you with that, and help you with someone who is trained in it, because it is hard to learn. It's not something, I presenting this, all of this took me a really, really long time to learn. And it's something that you can't learn overnight, and it takes a lot of practice. So I would highly recommend that if you're going to do something on your own, I wouldn't make any conclusions from it. I would talk to your provider about it.
That's great. Thank you. I also love that you called it the ultrasound police. Got a good laugh out of me from that. How can you differentiate between a double contour sign and an interface sign?
Yeah, double contour. So that's in reference to if a person has gout. And then an interface sign is differentiating between fluid and cartilage. So with an interface sign is typically what you're going to see is a single line. And what you're going to determine is that there is fluid on top of cartilage. And the reason why it gives that interface sign is because they have the two structures have the same echogenicity. They have the same brightness level or darkness level, I should say. And so the way the ultrasound machine differentiates between the two is it gives you, as it's passing through the fluid and then it hits the cartilage, even though it's the same echo texture and same brightness, it's going to say, oh, this is a different structure that's down here. So we're going to give you this line. It's called the interface sign. And so with that, I would say you use your dynamic imaging to determine that it's fluid. So kind of compressing on it, moving the joint and seeing that upper structure fluid kind of move around. Whereas with the double contour sign, that's more with gout. So with gout, you're not going to see, you may or may not see fluid. And what it is it's just those crystals. I forget what kind of crystals they're called, your crystals, I think. And they're kind of over the end of the bone where the joint is meeting. And so you're going to see kind of two lines, two kind of contour or two kind of interface signs. They kind of look like that, but you'll see two of them. And there may or may not be the presence of fluid there as well. And they're usually, the interface signs are very thin, whereas the double contour signs are a lot thicker.
Great, thank you. Is there anything about musculoskeletal ultrasound that you found to be surprising, maybe when you were in school or something you see every day?
Yeah, so I actually, I when I was in school, in physical therapy school, I didn't learn much about ultrasound. I knew of it. I think it was like a chapter it was a paragraph within a chapter of imaging in a book that I read, and so I didn't have a lot of knowledge going, in school. I didn't learn about it fully until I started working at the Hemophilia Treatment Center. And things that surprised me are two things. One is that how strong my anatomy is now, my knowledge of anatomy is now compared to when I was a student. I thought before I started working at the treatment center, I was like, oh man, my anatomy was so strong back in school. Now it's not as good. And then now that I've been using the ultrasound and I'm able to see the structures and kind of orient myself, kind of have that 3D image inside of my head, and now visualizing it on a screen, my anatomy is the strongest now that it's ever been, which is super helpful with kind of knowing where things are and knowing what things look like or supposed to look like. Another thing that's been surprising is just like how much, how different, but the same that like us humans, we look like. Obviously, under the skin, there's a normal appearance, but what might look really pathologic on one patient is completely normal on another patient. They may not have any symptoms. So just looking at that and being aware that like, hey, oh, this person like has a big structure that's sitting here, or it looks really different than my joint, but it's normal for them. And the reason why I know it's normal is because I look at their other side as well, and if they have the same appearance. And so it's you see like these anatomical similarities in that the echo texture and the brightness and darkness of certain bones and tendons, like that's the same across the board usually. But kind of how they're kind of put together is can be very different for every person. So that's been surprising for me as well.
That's fantastic. Thank you. I actually don't have any other questions for you now. So if you still have that poll up, but you haven't answered, please feel free to fill that out real quickly before we go ahead and sign off. But I just want to thank you, Peter, once more for taking the time to join us this afternoon. We appreciate your time and your expertise. I'd also like to thank each one of our viewers for joining us once again. It's been nice seeing you guys again after a couple weeks off. Please note that this recorded webinar will be available on Friday, September 16th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming weekly Wednesday webinar series schedule. For joining us this afternoon, I hope everyone has a wonderful day.